Dear committee, dear audience, let me begin by presenting the work that my team and I has been achieved over the past 9 months. So, recently we only have invasive methods available for screening abnormal glucose tolerance. This can delay early intervention, leading to an elevated number of diabetic patients and its associated complications. Here we show that continuous glucose monitoring as a dynamic method is the highly accurate tool to identify patients with abnormal glucose tolerance. Our data currently is insufficient to implement in clinical practice. However, understanding its sensitivity, specificity, and predictive values may lead to the very first dynamic glucose measuring tool, which alone can diagnose abnormal glucose tolerance. Therefore, policymakers and grant committees should consider integrating continuous glucose monitoring into their screening protocols for high-risk individuals. My name is Gabriella Rákóczi. I'm a dietitian, a CGM specialist, and a PhD student. My vision is to decrease the incidence of diabetes mellitus, and my mission is to identify and correct dysglycemia before it develops into diabetes. To achieve my mission, I have 3 specific goals. Let me introduce them one by one. The first project is about investigating the diagnostic accuracy of CGM on dysglycemia. Diabetes is a public health burden with immense healthcare and societal cost. Almost 500 million people are affected worldwide with elevated risk of premature death. Most of these cases are preventable with proper lifestyle changes. Most of these cases are diagnosed at a late stage, which can lead to serious complications. CGM is a tool that can measure blood sugar levels throughout the day. Conventionally used glucose measuring methods has their limitations as they only provide a snapshot or an average of the blood sugar levels. Our aim in this study is to investigate the diagnostic accuracy of CGM. Our clinical question is, do CGM metrics help identify the early signs of glycemic disorders? The population is a non-diabetic population. The intervention is CGM. We are comparing the conventional glucose data to the CGM data with the outcome of the detection of dysglycemia. Our hypothesis is CGM use can help identify the early signs of glycemic disorders. Here you can see our systematic search and selection. We found over 17,000 articles in 3 databases. And at the end of the selection process, we ended with 15 eligible articles. So on our first figure, you can see the mean differences in MAGE, in milligram per deciliter. MAGE is a key metric in CGM data. It represents the average of significant glycemic excursions over time. For this analysis, we included data of 550 patients from 7 cohort studies. And as you can see, the heterogeneity is quite high. The I-square is 75%, which can come from the fact that we included the global population. And it is well documented that East Asian population have significantly higher postprandial glucose excursions than Caucasian population. Despite this high heterogeneity, we have homogeneous results. It is well visible that in each case, the IGT group has higher MAGE levels than the NGT group. The pooled mean difference is 11.7 milligram per deciliter, meaning that in the IGT group, the MAGE level is 11.07 milligram per deciliter higher than in the NGT group. Our result is mathematically significant and clinically relevant, and it suggests that elevated MAGE levels increase the likelihood of having IGT. On our second figure, you can see the mean differences in time above range in %. So we are aiming for normal blood sugar levels, which is time spent in range. Anything above this represents time spent above range. For this analysis, we included data of 1,400 patients from 5 cohort studies, and the heterogeneity here is also high. The I-square is 90%, which can come from the same fact as I mentioned before. The pooled mean difference is 5.68%, meaning that in the IGT group, the time spent above range is 5.68% higher than in the NGT group. Our result is mathematically significant and clinically moderately relevant, and it suggests that higher time spent above range is associated with an increased likelihood of having IGT. On our third figure, you can see the mean difference in CGM 24-hour in milligram per deciliter. This is basically the mean blood sugar level throughout the day. For this analysis, we included data of 560 patients from 7 cohort studies. The heterogeneity here is low, and the pooled mean difference is 7.20 milligram per deciliter, meaning that in the IGT group, the mean blood sugar level is 7.20 milligram per deciliter higher than in the NGT group. Our result is mathematically significant and clinically relevant, and it suggests that elevated mean blood sugar levels associated with an increased likelihood of having IGT. Our strengths are the robust methodology, the large sample size, and that despite high heterogeneity, we had homogeneous results. And our limitations are that the included studies may differ in monitoring duration and the lack of standardized CGM-based cutoff values for dysglycemia. So as a conclusion, higher MAGE, TAR percent, and 24-hour CGM values are associated with an increased likelihood of having abnormal glucose tolerance. And the implication for practice, currently, CGM is a good tool to apply with the conventionally used diagnostic tools. And the implications for research further investigated the diagnostic accuracy of CGM, like predictive values, sensitivity, and specificity, and established cutoff values for CGM. Here you can see our progress so far. We just submitted our article. On our second project, we are investigating the diagnostic performance of CGM. This is a clinical registry analysis. Only in the US, 1 in 3 adults have prediabetes, and 80% of these individuals are unaware they have it. CGM offers essential insights into glycemic variability in everyday situations and can potentially detect early dysglycemia. So in this project, our aim is to investigate the diagnostic accuracy of CGM and established cutoff values for prediabetes. The clinical question is, what is the diagnostic accuracy of CGM compared to hemoglobin A1C in detecting dysglycemia? The population is non-diabetic population. We are comparing the CGM data to the conventional hemoglobin A1C data with the outcome of the detection of dysglycemia. Our hypothesis is that CGM metrics are more sensitive than hemoglobin A1C in detecting early dysglycemia in non-diabetic population. And the implications are validation of CGM metrics, development of new screening protocols, and also preventive screening for high-risk individuals. In our third project, we are investigating the effect of non-pharmacological interventions on the reversal of type 2 diabetes. Type 2 diabetes has reached epidemic proportions globally, even if it's not an infectious disease. It is driven by factors like poor diet, physical inactivity, and also obesity. So we believe that dietary and lifestyle changes could lead to type 2 diabetes remission. Our aim here is to investigate the effect of non-pharmacological interventions on the reversal of type 2 diabetes. The clinical question is, do lifestyle factors help reverse type 2 diabetes? The population is type 2 diabetic population. The interventions are different lifestyle changes with the outcome of the remission of diabetes. Our hypothesis is lifestyle changes can help reverse type 2 diabetes. The clinical question is, do lifestyle factors help reverse type 2 diabetes? And the clinical implications are reduction in complications, decreased medication dependence, and also improved quality of life. So to summarize, I have 3 ongoing projects. We just submitted the first one. We are planning to submit the second one next January and the third one next December. And I'm thanking your attention with my favorite quote, an investment in knowledge always pays the best interest. Thank you for your attention.
Okay, thank you and congratulations. Is there any question? Yes.
So may I ask that what your personal opinion about the advantages of using CGM compared to the traditional measurements?
There are many, but I will tell 2 or 3 maybe, which are really important ones in my opinion. The first one would be that using CGM has an immense behavior effect. So I'm using it each day. So in my practice, I'm working with CGM, and I see patients going with this tool for 2 weeks period, and I see that they are changing their behavior. So as they are seeing the effect of certain nutrients on their blood sugar levels, they are immediately starting to change their diet. So it is one thing that is very interesting and important. The second one is that conventional glucose measuring methods has their limitations. With the CGM tool, we can also show the variability, so the daily fluctuation of the blood sugar levels, which is very important, and that is missing from those methods, from hemoglobin A1C, from fasting glucose, and from OGTT. Those are only snapshots or average values. And I think these are the most important. We have a lot, but these are the most important. It is easy to use also. It causes any pain. So that's a very good thing. For high-risk individuals, I think we should use it more.
Okay. Thank you. Can I ask the price of this
instrument?
The price. And how would you recommend your patient? What are the high-risk patients?
Yeah, the price, currently the price is high, so I hope it will be more user-friendly in the future. So those who are at high risk, I believe that they are patients with family history, yeah, who have some degree of diabetes relation, or obesity is also a risk factor. Age is an independent risk factor, so after a certain age, I recommend to use it as a prevention tool as well. I think these are the most important.
Can it be bought in a pharmacy? I mean, the instrument?
Think yes. Now we can in Hungary as well, because there is a Hungarian company who are starting to do these kind of tools to make them, and I saw it in a pharmacy, so there's a chance to be more available.
Okay, thank you. And there was one more question.
Congratulations, so impressive progress. So regarding your second project, so you would like to compare the hemoglobin A1C to the CGM, but in non-diabetic patients, and I'm not sure, how can you reach hemoglobin A1C levels in non-diabetic patients, because I think this is not routinely collected, or how can you compare with a real life hemoglobin A1C?
Yes, thank you for your question. In our second project, the clinical registry, you think, yeah. So this registry is a Israeli-based cohort with 10,000 individuals. At baseline, we excluded those patients with diabetes, those who are diagnosed based on hemoglobin A1C with diabetes. We keep the rest of the patients. And then we see their hemoglobin A1C levels. And we know that hemoglobin A1C, where are the cutoff values for hemoglobin A1C for prediabetes. And based on that, we're comparing that those patients, CGM data what are they telling to us? So we are looking for the glycemic variability, we are looking for the time spent above range, so high blood sugar levels, mean daily blood sugar levels, MAGE levels, as I showed on one of my figure, and these important data. And this is the base where we can identify, based on CGM values, who are the patients with prediabetes and who are with normal glucose tolerance.
Thank you.
Thank you.